Vanakkam. Tendon transfer for correction of the claw deformity in ulnar nerve palsy is definitely important. But there are other problems that occur in the hand affected by ulnar palsy that are also important and also need correction. For example, the thumb pinch, which is very weak in patients with ulnar nerve palsy. Next, the transverse metacarpal arch, which is completely lost, or the Wartenberg sign that we come across, or even the loss of the long flexors of the ring and little fingers in patients with high ulnar nerve palsy. All these have to be corrected with correct tendon transfers. What are the transfers available for the correction of these problems and how are they done? All this will be seen in this video. We have already seen in a previous video that restoring function in ulnar nerve palsy will mean correction of the claw deformity, restoration of the thumb index key pinch, restoration of the transverse metacarpal arch, correction of the little finger abduction deformity, and restoration of finger flexors in high ulnar palsy. Of these, we have already discussed the tendon transfers needed for correction of the claw deformity in an earlier video, and you can click on the icon above to see that video. In this video, we are going to deal with the other parameters, that is restoration of the thumb index key pinch, restoration of the transverse metacarpal arch, correction of the little finger abduction deformity, and restoration of finger flexors. Let us consider first restoration of the thumb index key pinch. Is there actually any deficit in the key pinch in patients with ulnar nerve palsy? If so, why does it occur? And of course, how can it be restored? Normally, thumb adduction is mainly by the adductor pollicis and the first dorsal interosseous muscle, these two muscles acting as a force couple. So, both the adductor pollicis and the first dorsal interosseous contribute significantly to the force of thumb adduction. In ulnar palsy, there is 80% loss of power pinch. This is because the three important muscles involved in the power pinch, that is the adductor pollicis, the first dorsal interosseous and the flexor pollicis brevis, are all paralyzed. Please click on the icon above to understand these altered dynamics better. So, as only the flexor pollicis longus and extensor pollicis longus are acting and they are weak adductors, we have a very weak pinch in these patients. Also, due to the biomechanical causes, that is the large momentum of these two muscles at the level of the metacarpophalangeal joint and the interphalangeal joints, it leads to what is known as the Z deformity, that is hyperextension at the metacarpophalangeal joint and interphalangeal joint flexion. So the adductor pollicis not only is important for adduction but also for flexion of the metacarpophalangeal joint of the thumb by virtue of the location of its insertion. To restore the thumb index key pinch, we need to restore a strong adduction of the first metacarpal, active flexion of the hyperextended metacarpophalangeal joint of the thumb, active extension of the hyperflexed interphalangeal joint, and stabilization of the index finger metacarpophalangeal joint. So basically, we need to do two types of tendon transfers. One, tendon transfers to restore the thumb adduction, which can be done with the extensor carpi radialis brevis, flexor digitorum superficialis, or the extensor indicis proprius. And the second function to be achieved is restoration of index finger abduction, which can be done in three methods. By three methods, using a slip of the abductor pollicis longus, extensor indicis proprius, or the palmaris longus. Let us first consider the methods of restoring thumb adduction. The commonest method used is the extensor carpi radialis brevis transfer described by Smith in 1983, where a transverse direction of pull across the palm deep to the flexor tendons to insert into the tendon of the adductor pollicis is used. A small dorsal transverse wrist incision is made. The extensor carpi radialis brevis tendon is divided at its insertion in the base of the third metacarpal. the tendon is retrieved in the distal forearm by another incision. Now, a transverse incision is made over the proximal end of the intermetacarpal area. It could be between the mid and ring or between the index and mid fingers. Through this incision, a small window is created through the interosseous fascia by excising some of the paralyzed interosseous muscles. Having done that, a longitudinal incision is now made on the ulnar side of the metacarpophalangeal joint of the thumb, and tunneling is done from here deep or dorsal to the transverse head of the adductor pollicis muscle through the window that we have created in the interosseous fascia into the dorsal hand wound. A free tendon graft, which could be the palmaris longus or plantaris, is harvested and sutured to the tendon of the adductor pollicis first. The proximal end of this tendon graft is passed through the tunnel that we have created and then subcutaneously into the distal forearm incision and sutured to the extensor carpi radialis brevis tendon. And when suturing this tendon graft to the extensor carpi radialis brevis tendon, the positioning is such that the thumb lies just palmar to the index finger when the wrist is in neutral position, and when the wrist is extended, the thumb should fall into abduction, and when the wrist is in flexion, the thumb should lie firmly against the palm. The second type of transfer to restore thumb adduction was described by Edgerton and Brand in 1965, and they used the flexor digitorum superficialis of the ring finger for this purpose. If it is used in a patient with isolated ulnar nerve palsy, the insertion of this tendon is to the adductor tubercle. But if used in a patient with combined ulnar and median nerve palsy, the insertion is made to the radial expansion of the extensor apparatus of the thumb to achieve pronation. The technique by which this procedure is done is by first harvesting the ring finger FDS and withdrawing it into a palmar incision. This free end of the tendon is now passed around a natural pulley, usually a natural window in the palmar fascia over the neck of the region of the third metacarpal, and then it runs across the palm parallel to the transverse head of the adductor pollicis to the thumb, deep to the neurovascular bundles and finger flexor tendons. The third type of tendon transfer to achieve thumb adduction is the extensor indicis proprius transfer described by Brown in 1974. In this procedure, the extensor indicis proprius tendon is detached from the extensor hood. The incision is retracted ulnarly to expose the middle ring intermetacarpal space. The tendon now goes through this intermetacarpal space along the transverse muscle belly of the adductor pollicis and is finally sutured by inserting at the adductor tubercle on the ulnar side of the metacarpophalangeal joint of the thumb. Next, we shall consider tendon transfers that can achieve index finger abduction. And here we shall talk about the three most commonly done procedures using the slip of the abductor pollicis longus, the extensor indicis proprius, and the palmaris longus. The technique used by Neviaser, described in 1980, uses one of the slips of the abductor pollicis longus. Rather than exact abduction of the index finger, it provides stability to the index finger so that when the key pinch is performed, the index finger can individually withstand the pressure from the thumb, because it is important that the index finger plays some active role in the pinch. To perform this transfer, the abductor pollicis longus tendon is exposed, and one slip that inserts onto the thumb metacarpal base is identified, and this should be preserved. An accessory slip is detached and a subcutaneous tunnel is created from the radial styloid to an incision on the radial side of the proximal phalangeal region of the index finger. A free tendon graft is harvested and attached to the insertion of the first dorsal interosseous muscle. The free end of this tendon graft is now passed through the subcutaneous tunnel and interwoven into the abductor pollicis longus slip, making sure that the index finger and the wrist are in neutral position. This picture shows the extensor carpi radialis brevis has been used for thumb adduction, and an accessory slip of the abductor pollicis longus has been used for index finger abduction. So this will provide an excellent key pinch. The extensor indicis proprius also can be used to provide index finger abduction. This can be done by dividing the EIP tendon and withdrawing it through another incision at the level of the dorsum of the wrist and then rerouting it distally under the index finger EDC and around the radial border of the index finger to suture to the insertion of the first dorsal interosseous muscle. The obvious disadvantages of using this tendon transfer are the short moment arm and the narrow angle of approach. When the palmaris longus is used to provide index finger abduction, it can be lengthened with the strip of the palmar fascia as is done in the Kamitz transfer and then tunneled subcutaneously across the dorsum of the base of the thumb and then along the radial side of the index finger metacarpal to be inserted into the tendon of the first dorsal interosseous. The next important correction to be done in a hand affected by ulnar nerve palsy is restoration of the transverse metacarpal arch, and this can be done either by using the flexor digitorum superficialis in the technique described by Bunnell or the extensor digiti minimi in the technique described by Rani or the extensor carpi radialis longus in the technique described by Palande. Normally, there is a gentle concave volar transverse metacarpal arch at the level of the metacarpal heads. This is maintained by the tone of the interossei muscles and the hypothenar muscles. This arch is important to maintain the strength of the fist in power movements and in cupping of the hands, as in holding water or picking up semi-solid food with the hands, like the example of eating rice, or even in finger precision movements involving the ring and little fingers. This arch can be well made out on examining the dorsum of the knuckles on making a fist. In the normal hand, it would be a curve. In the hand with ulnar nerve palsy, it would be flat. This function can be achieved by the intrinsic muscles through a combination of adduction, abduction and flexion at the metacarpophalangeal joints and can produce digital rotation. And it is very useful in the precision grip or even the power grip like tool handling and cupping of the hand to hold water or grasp large objects. It is particularly important in countries like India where we eat rice with our hands. So in ulnar palsy, this transverse metacarpal arch is lost and we need to restore the normal curve. And one of the techniques of achieving this is the Bunnell's T operation described in 1964. In this procedure, the flexor digitorum superficialis of the ring finger is detached and retrieved proximally in the palm. Now, a free tendon graft is harvested, either the palmaris longus or the plantaris. One end of the graft is inserted into the radial aspect of the base of the proximal phalanx of thumb and the other is inserted into the ulnar aspect of the neck of the little finger metacarpal. The root of this tendon graft will be under the flexor tendons and under the digital neurovascular bundles. Now, the retrieved flexor digitorum superficialis tendon is attached to the middle of this free tendon graft. After this attachment, it will now look like a T. The horizontal limb formed by the free tendon graft and the vertical limb of the T formed by the flexor digitorum superficialis tendon. When the flexor digitorum superficialis contracts, it produces adduction and flexion of the thumb and little finger, and the T that had been formed is now converted to a Y with restoration of the metacarpal arch. The next type of transfer that can restore the transverse metacarpal arch is the extensor digiti minimi transfer described by Rani. The extensor digiti minimi is cut from its insertion into the extensor expansion at the level of the dorsum of the metacarpophalangeal joint of the little finger, retrieved proximally through another incision made on the extensor aspect of the forearm, then passed subcutaneously to the volar aspect where it is sutured to the neck of the fifth metacarpal. As a result of this, what was originally an extensor of the metacarpophalangeal joint will now be a flexor and a rotator of the metacarpophalangeal joint of the little finger. The third procedure that can also restore the transverse metacarpal arch is the EF5T procedure or the Palandes transfer that we have already discussed earlier in the video on correction of the claw deformity. So this transfer not only corrects the claw deformity but also restores the transverse metacarpal arch. Now let us see procedures that can correct the little finger abduction deformity. The commonly done procedure to achieve this correction will be the use of the extensor digiti minimi. First, we need to understand why the little finger has this abduction deformity. Normally, it is the abductor digiti minimi that abducts the little finger, but the extensor digiti minimi can also do this as it is attached more on the ulnar aspect of the metacarpophalangeal joint of the little finger. And countering these two muscles is the third palmar interosseous, which adducts the little finger. In ulnar palsy, the abductor digiti minimi and the third palmar interosseous are paralyzed. So, there is unopposed action of the extensor digiti minimi leading to abducted position of the little finger known as the Wartenberg sign. This is not only a cosmetic deficit but also a functional deficit. So we need to provide adduction of the little finger. To achieve this, the extensor digiti minimi can be split and used. First, the ulnar half of the extensor digiti minimi tendon is detached from the extensor hood of the little finger. This detached tendon is retrieved through an incision just distal to the extensor retinaculum. It is then passed again through the fourth intermetacarpal space into the palm. Now, where should this tendon be inserted? It depends on whether there is no claw deformity or whether there is a claw deformity of the little finger. If the little finger is not clawed, the tendon slip is sutured onto the insertion of its metacarpophalangeal radial collateral ligament on the proximal phalanx. But if the little finger is clawed, the tendon is inserted onto a radially based flap of the flexor tendon sheath just distal to the A2 pulley, otherwise known as the Brooks insertion. Now this is done so that we can achieve not only adduction of the little finger but also flexion of the metacarpophalangeal joint and hence correction of the claw deformity of the little finger. The final procedure required to restore function in the hand affected by ulnar nerve palsy is the restoration of finger flexors, and this will be required only in patients with high ulnar palsy. In high ulnar palsy, that is, involvement of the ulnar nerve proximal to the elbow, there would be a significant functional deficit because of the paralysis of the flexor carpi ulnaris and the flexor digitorum profundus to the ring and small fingers. Of these, the flexion of the distal interphalangeal joints of the ring and small fingers can be restored by side-to-side tenorrhaphy of the FDP to the ring and little fingers to the FDP of the middle finger. It is better to avoid including the FDP of the index finger also, as we need to preserve some amount of independent movement of the index finger. This procedure will improve the power grip in the hand. In patients requiring strong ulnar deviation and flexion of the wrist, that is, those who require replacement of the flexor carpi ulnaris, transfer of the flexor carpi radialis tendon can be done to the flexor carpi ulnaris. So, we have seen quite a lot of procedures starting from correction of the claw deformity to correction of the other deformities in ulnar palsy. We can summarize the procedures and see which would be the best according to the studies that have been done. For claw correction, the FDS transfer is supposed to give 92% good to excellent results, and the EF40 procedure has been shown to give 86% good to excellent results. The Palandes transfer is shown to be efficient in cupping the hand, and as far as restoration of grip strength is concerned, EF40 procedure has been shown to be the most effective, and in restoration of key pinch between the thumb and index, the extensor carpi radialis brevis transfer to the adductor pollicis and slip of the abductor pollicis longus to the first dorsal interosseous have been shown to be the most effective. I hope you liked the video. I enjoyed making it. Please do click on the shown links to see the other parts of management of ulnar nerve palsy like the nerve surgery and the static procedures. And do not forget to subscribe to stay connected with the latest in learning hand surgery.